Alright, we're going to smash 10 more questions on the general gastro medicine section of Passmed. Let's go. What's the question? Which one of these following complications is most likely to have occurred? A 62-year-old woman, history of scleroderma. This is going to really be into the recesses of my memory, but let's go. She's suffered with recurrent bouts of diarrhea. During these bouts, stools are pale, bulky, offensive. Drinks 14 units of alcohol a week. Amateur hour. Alright. Blood shows the following. HB normal, platelets normal, white blood cells fine, ferritin a little bit low. Ferritin's low, B12 is low, folate is also low. Low, sodium fine, potassium a bit low, urea fine, creatinine fine. Bilirubin, these look absolutely fine, these LFTs. I wasn't sure if albumin was going to be low, some sort of dietary insufficiency thing. But okay, stools are pale, bulky and offensive. What is going to be going on here to cause these deficits and lots of diarrhea? Whipple's disease, pretty rare. I'm pretty sure it's a bacterial disease, something Whippelli. Obviously we have Whipple's procedure or a pancreaduodectomy, one of my favourite words to say on Gen Surge, but that sounds pretty rare. I actually don't know much about Whipple's disease itself. Colonic hypomotility, maybe is this, I don't know about hypomotility being necessarily a thing or how you'd fix it. Chronic pancreatitis would cause some pale stool and it would be offensive. Sounds like some sort of a bacterial overgrowth thing. Malabsorption syndrome, pretty sure that's caused by some bacterial overgrowth. Ileostenosis. Now, we do have deficiencies in B12, which is obviously absorbed at the terminal ileum. Given that there's a few other things going on, I'd expect them to talk a bit more about maybe have an MCV in here or something if they're talking about an anemia of some sort. This is a really tricky one. I did say something about bacterial overgrowth just because it's smelly, offensive, stools are pale. So maybe malabsorption, is that going to be the key? Is there going to be an issue with bacteria? But then we've got LFTs which are completely fine, so I don't think it's going to be pancreatitis. I don't think ileostenosis. Whipple's disease, no idea. Malabsorption or hypomotility, let's see. Okay. Alright, that was a little bit more of vibes. I'm not going to lie. What is Whipple's disease? Tropharema Whippelli infection. Okay, arthralgia, weight loss and diarrhea. Okay, so none of those things. This is all about scleroderma. I had no idea about scleroderma and its indication for malabsorption syndrome, but hey, every day is a school day. Next up, we have what medication needs to be commenced. Alright, a 42-year-old woman, history of alcoholic cirrhosis, presents to ED. I bet she's drinking more than bloody 14 units a week. 2 episodes of vomiting blood. Alright, not healthy, not ideal. She has spider nevi, jaundice, sclera, abdomen distended, dull, so she's got full-blown ascites as well. OBS, bit tacky, hypotensive, otherwise okay. Blood sample being taken, IV blood started, you shove some fluids into her to raise that hypotension. She's on an emergency list for endoscopy. What meds need to be started? Well, I think this is going to be, it sounds like one of her varices. If she has cirrhotic liver, she's probably got varices, and I'm pretty sure we go telepressin and prophylactic antibiotics before we do anything like that. I feel like there was something about telepressin and whether or not you give antibiotics. I remember having people with these types of bleeds on the ward. We would do the Hong Kong protocol. Were they on antibiotics? They were at that time as well. So Hong Kong protocol is actually talking about a continuous PPI infusion, which, I mean, we've got up here, but I feel like if she's going to endoscopy for this stuff, it's going to be quench those blood vessels and antibiotics before endoscopy. And patients with variceal hemorrhage, the infusion, PPI should be offered for patients with non-variceal bleeding following endoscopy. Okay, so this is what you do after the fact, and if it was non-variceal bleeding. So maybe like a sort of gastric ulcer bleed or something like that, which I think is what happened to the guy I'm talking about. Fine, okay, we like those questions. Well, we like getting questions right. Most likely diagnosis. 23-year-old woman referred to neurology clinic after developing a unilateral hand tremor. Unilateral tremor. Past 12 months, family reports changes in mood, behaviour associated with some speech problems. On exam, tremor is in right hand at rest, okay? So it's not an intention tremor. Resting tremor. Also with paucity in movement and some bradykinesia. Dark circle marks are noted around the iris. I do know some Kaiser Flasher rings, some Wilson's disease. Patient reports that uncle died of liver cirrhosis at age 40. Give them some penicillamine. Is that what we used to do or still do? Kaiser Flasher rings, excellent. Is it penicillamine? I haven't thought about this stuff in a long time. Some copper chelation therapy. Alright, we like how this is going. What would be required for definitive diagnosis of this condition? 22-year-old woman presents GP clinic with some blood tests. She's suffering from fatigue, bloating. Blood results show the following. HB fine, platelets fine, white blood cells, ferritin fine. These are raised, so these are some antibodies. Alright, TTA. Tissue transglutamase IgA is also raised, so we're thinking one thing and one thing only, is that she might be celiac. This sounds like celiac, which you need to take whilst having gluten in your diet so you can see the atrophied villi, as we all know. Nice. Some biopsy, gold standard for diagnosis of celiac disease, performed in all patients with suspected disease following serology. Which of the following is the likely diagnosis? Hank. A 76-year-old, presents to GP with jaundice, heavy drinker, consuming approximately 35 to 40 units per week. There is no history of abdo pain, no pain at all. However, exam does reveal a palpable gallbladder. I remember teaching some students about this. I might mispronounce it from memory. I think this is Korsav's sign. A palpable gallbladder and no abdo pain. So there's one thing that we're thinking. These are going to be saying albumin fine, alk phos up, T a bit up, bilirubin up, INR also a bit up, obviously. It'd be just one in a normal person. Gallstones, we'd expect some pain on the palpation. Could this be sort of a cholangiocarcinoma or some sort of cholelithiasis or something? You'd be expecting some pain, paracetamol overdose. They haven't indicated that, there's no history of it. PBC, also don't think so. Hepatitis, I wouldn't explain the palpable gallbladder. Here we go. Courvoisier's sign. That sounds far more fancy than Korsav's sign. Alright, next question. Question 6. A 58-year-old man, long-standing history of undergoes upper GI endoscopy. What's the next step in management? Right, he's having some endoscopy. This report shows 2 centimetre segment salmon coloured mucosa around the GOJ. Alright. Salmon coloured, that doesn't sound very tasty. A histology confirms intestinal metaplasia. No evidence of dysplasia. It sounds like we're talking about Barrett's esophagus here, which is the metaplasia. Oh, I'll get this the right way around. Squamous 2 columnar epithelial cells around the GOJ, distal esophagus. He is currently taking a PPI, which is required for symptoms. Okie doke. Right, so we're thinking he has some Barrett's esophagus, because there's some metaplasia. There's no dysplasia. So what do we do with this information? I think we're worried about it becoming cancerous. That's the main issue with this dysplasia. We would want to follow this up. Would it be annually? Continue medication discharge? I don't think so. I think you want to, and I don't think radiofrequency ablation's either indicated. We do want to give him more PPIs. Now, do we do it 6 months or 3 to 5 years? See if there was maybe any evidence. I think they go mild and then moderate and severe. So I have a vibe that it's going to be 3 to 5 years, but it could be 6 months. Is it sort of like 3 months and then 6 months? I actually don't know the routine. I'm really in between these two. Let's see what this says. Well, we can take some satisfaction in the fact that more of us got this wrong than got it right. It's these kinds of regimes that I just don't know, or haven't memorised, because I don't work in Gastro, but At least we know some high-dose PPI and some surveillance. That's good enough for us. Let the gastro people figure that out. What is the most appropriate first-line med to induce remission? Next question. 27-year-old woman, bloody diarrhea. Started about 6 weeks ago, passing 3 to 4 loose motions a day. Can contain some blood. Other than feeling lethargic, she feels well. Abdo pain. Colonoscopy performed, shows inflammation, ascending, transverse, descending, consistent with ulcerative colitis. That's what I thought we were doing. Ulcerative colitis, blood shows the following. HP is fine, platelets fine, white blood cells fine, CRP is a bit raised. Okay, well, that's not too unusual. First line to induce remission. I think we do oral immunosalicylate. Would you do rectal as well? I feel like it's down to where the disease is, isn't it? And they're saying that it's all over the colon. Would you do, I imagine you would do oral all over. Maybe if it was just proctosigmoidal, you'd only do rectal. Would we do IV steroids? She's systemically well. I think you go IV if it's getting to 5 or 6 loose motions a day. I can't really remember the pathways. Alright, there we go. This is a mild, moderate flare of extending past the left colon. Oral aminosalicylates should be added. Excellent. Okay, I feel like that's pretty straightforward. Here we go. 4 to 6 stools, very much blood. Mild, moderate, severe. What VA? Okay. This is where we're talking. This is the kind of vaguities that I'm remembering from this disease. V is just for severe. Mild to moderate, then you can just do orals and topicals. We have another question. Oh, another diagnosis. You review an 18-year-old girl in the outpatient medical unit. For the past 4 months, she's had episodes of repeat severe vomiting lasting a few hours. This is preceded by intense sweating and nausea. She has noticed a reduction in appetite this period. Clothes fit looser. Hospitalized once in the last 4 months for dehydration. Weird. She has past medical history, migraines, no psychiatric history, some blood tests were unremarkable. And what's the diagnosis? Okay, well, she's vomiting a lot and she's been dehydrated. She's had sweating and nausea. Okay, psych seems to be fine. 18-year-old girl. I feel like they're not going for this because it seems like there's other stuff going on. It sounds a little bit too intense just for Gord. The unusual. It's an 18-year-old. We don't know anything else out about her. Crohn's? Could this be Crohn's? I feel like there'd be more sort of GI systems, GI involvement, rather than just vomiting if it was Crohn's. Hematoma sounds quite tempting with that sweating and nausea and vomiting. Blood tests normal though. That's really weird. Cyclical vomiting syndrome and Crohn's disease. This is quite a tricky one. I would have expected some blood tests to be different with pheochromocytoma. Cyclical vomiting syndrome just doesn't really sound like these other ones. But you would get losing weight if you were having flares up of Crohn's. Bloods are all fine though. Maybe it's just me who's never heard of cyclical vomiting syndrome. Severe nausea and vomiting last few hours. Management, prophylactic treatment, amitriptyline, propranolol, topiramate. Okay, and ondansetron treatment for ondansetron, chlorperazine, and triptans in acute episodes. Here we go. 32-year-old man tested Hep B after an accidental exposure at work. Alright, interpret these results. Okay, let's start from the top. He does not have active infection, HBsAg. He does have serum antibodies, and for the core antibodies, these look negative. So he's only got serum. Sounds like that would be from vaccination in that instance because he's never had the disease before. Surely it's that. Okay. Alright, that seemed like a more straightforward one. I swear I nearly always get those ones wrong just because I start to doubt myself, but that was actually the easiest version of Hep B bloods I've ever had. What is the most important initial investigation? 31-year-old man, background of moderate UC, takes mesalazine, presents warm, weak history, feeling unwell, sore throat and fever. Okay, his bowels seem to be fine. Oh, important initial investigation. Right, CRP will show some general inflammation, FBC for a full sweep, monospot test. I don't know if mesalazine or UC make you have EBV more than usual, but I don't think so. No investigation required. or a throat swab to test. He's got, Gene, feeling generally unwell. I'd always want a FBC. Is this going for a neutropenia kind of thing? I feel like mesalazine might cause some neutropenia, potentially. Immunosalicylates are often associated with a variety of hematological adverse effects. Okay, agranulocytosis. That's what we like. Pretty easy. Monosort fever for glandular fever. It's helpful if glandular fever is suspected, but it's not the most important one. EBV, glandular fever. Yeah, easy. And that's a pretty good result. 90%. We'll take that to the bank. That's John Pincock.